Hey, and did you know I'm currently accepting new patients in New York, offering both in person and telehealth visits? And I also provide telehealth for patients in Michigan, with North Carolina coming soon. And I also offer coaching, both intimacy coaching and menopause coaching, nationally and internationally. So look us up on www.femvhealth.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about updates in menopausal hormonal therapy. And remember that this is not any type of medical advice. If you're having any hot flashes, night sweats, mood swings, you can come to my office. I have an office in New York and I do telemedicine for Michigan and soon North Carolina as well. Or you can go to the menopaussociety.org if you are not in any of those states and get the help that you need. And remember, this is not any type of religious advice. So if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today, what I'm going to talk about is just a lot of little updates. I mean, most of you that have been following us or follow, all the other physicians that talk about menopause probably have a lot of this knowledge. But for those that don't, I am here and I am going to update you. So let's get started. So what we're going to do is we're going to, first of all, begin with the WHI study. And of course, you can't have really any discussion about hormones from, where we've been to where we're going without at least talking or mentioning about the WHI study and what happened and how we are where we are today, right? So let's go ahead and get started. So the WHI, which is the Women's Health Initiative, really changed prescribing patterns. And so millions of women stopped hormone therapy overnight without medical guidance. And clinicians who had been prescribing hormones for, decades suddenly stopped. And then that happened in 2002. And so now clinicians that had been prescribing hormones appropriately stopped, and now for over 2 decades, an entire generation of women were denied treatment that was evidence-based and, given at the right time. It was safe and effective for the right population, right? So let's get into it a little bit. So the WHI was the largest randomized controlled trial of postmenopausal women that was ever conducted in the United States. It enrolled 161,808 women across 40 clinical centers between 1991 and 2002. The clinical trial was conducted to examine the effects of estrogen and progestin on various health benefits and risks in postmenopausal women. The trial was supposed to last for about 8.5 years, but was stopped at 5.2 years because the National Heart, Lung, and Blood Institute accepted the study's data and Safety Monitoring Board's evaluation that the risks of breast cancer were increased and other health risks of hormone treatment were greater than the benefits. So basically what happened, right, is that this study, here we have the study, it's like humongous, it's really big, and it was supposed to go for 8 years. It was stopped at 5 years because they felt that the risks outweighed the benefits. Right. So additional papers which extended the evaluation of this data were published on 2 subgroups of stroke and coronary heart disease and breast cancer. So the hormone therapy arm examined 2 specific agents. We know that we looked at, conjugated equine estrogen, which was 0.625 milligrams, and then medroxyprogesterone acetate, 2.5 milligrams. And, those that had a uterus obviously had both the estrogen and progestin, and those that didn't have a uterus only received the estrogen alone. The average age of the participants was 63 years. The range was from 50 to 79. And most of these women were years, if not a decade, into postmenopause. and most women were asymptomatic. So what happened? So the WHI was designed to study the effect of hormone therapy on chronic disease prevention in older postmenopausal women. And it was not designed to evaluate management in recently postmenopausal women. So the problem is that once, they started to get the results from this study, the WHI failed to acknowledge reporting non-significant results. So the problem that, so if you read the evaluation of the WHI by Dr. Avram Blooming, you'll see that he talks about in his paper entitled "'Tis But a Scratch." It came out in 2023. And he talks about what were the problems with the WHI. And he states that, they failed to acknowledge reporting non-significant results. They used nominal rates as primary statistic and did not adjust for factors that could create false positive results. They used their nominal data breast cancer rate. So he said that they're using their nominal rates as primary statistic and they didn't adjust for factors that could have created a false positive result. Okay. And he's saying that even if you used their nominal rates, right? So whatever increase that they saw, still it would not increase the rate of breast cancer for those individuals that used conjugated equine estrogen and the medroxyprogesterone acetate. Okay. He also notes that the WHI did not show statistical significance or association between the conjugated equine estrogen and the medroxyprogesterone. He states that other problems with this, with the results of the WHI, is that they misinterpreted their own data. They had misleading assertions that it reduced the incidence of breast cancer in the U.S. That the WHI study was done on women 12 to 15 years into postmenopause, and women were without their premenopausal levels of estrogen and progesterone long enough to bring about changes in various bodily functions, which were the precursors of disease or undiagnosed disease, right? So we know that the longer you go without hormones, we know that cardiac disease starts up if it wasn't already there to begin with, but it accelerates. We know that women start to have an acceleration of bone loss within the first few years of menopause. And so they're at a higher risk of osteoporosis. And so we know that a lot of these chronic conditions start as we start to go into postmenopause. And definitely, 10 years into postmenopause, we've definitely established some of these chronic diseases, such as coronary vascular disease and, the beginnings, who knows, of osteoporosis. And some women get, that were before, right, even menopause, they were osteopenic and then afterwards can become osteoporotic. So really important. The findings of the estrogen progestin study should have been, and this is according to Dr. Avram Blooming, and he feels that that the results of that WHI study should have been that there were no significant risks that were found in cardiovascular disease, invasive breast cancer, stroke, venous thromboembolism, but instead what they noted that it was actually the opposite. Okay. So the error was in the extrapolation of the study. And then when the results were published in 2002 and the estrogen progestin arm was halted early, the medical community applied those findings universally to every woman, right? So they said that, all women, no women could have hormones because the risks were greater than the benefits. And they did not advise that women go on hormones. We know that conjugated equine estrogen alone significantly reduces breast cancer risk and breast cancer mortality. That conjugated equine estrogen and medroxyprogesterone acetate, when started in hormone therapy naive women, does not increase breast cancer risk and does not increase breast cancer mortality, even for women with a family history of breast cancer. Okay, so that's important to know and understand. And this is from a paper with Dr. Hodis, along with Dr. Blooming. So they kind of wrote this synopsis of the WHI study. Even if the WHI estimate of the increased risk of breast cancer is accepted based on the elevated hazard ratio, a result driven solely by a low incidence of breast cancer in the placebo group, conjugated equine estrogen and medroxyprogesterone acetate would be responsible for less than one additional non-fatal breast cancer diagnosis for every 1,000, right? So they're saying that even if we accepted that, their nominal rates of increase in breast cancer with the combination of the conjugated equine and the medroxyprogesterone acetate, even if we accepted that that data was correct, that it would only result in one additional non-fatal breast cancer diagnosis for every 1,000 women, right? So it's saying that, for the most part, hormones, as we know, are safe for women in postmenopause. And even if we accepted the data from the WHI as it was written, it would only lead to an increase of one additional breast cancer per 1,000. And that they truly believe that there was no estimate of an association between conjugated equine estrogen and the medroxyprogesterone acetate that remains statistically significant with per protocol adjustment. Okay, so in the results of the WHI study, they had said that it was clinically significant, but when people went back and reevaluated that data from the WHI study, they noted that it was not clinically significant. The increase that they had noted in the arm that had the conjugated equine estrogen and the medroxyprogesterone acetate. Also, what's important to note is that initial unadjusted statistics from the WHI reported that women that began combined menopausal hormonal therapy had a higher rate of developing chronic heart disease, stroke, breast cancer relative to the placebo arm. But after statistical adjustment, these associations with the coronary heart disease, stroke, and breast cancer were found to be not statistically significant. Okay, so these are all important things, right? Is that they were saying that, there was this arm that had all of these risks, right, with the heart disease, with the breast cancer and stroke. And what they're saying is when we went back and looked at it, it was actually not statistically significant. In instances where the WHI adjusted for confounding factors, the results for an association between conjugated equine estrogen and medroxyprogesterone acetate and breast cancer were not statistically significant. So this is why this is all really important, right? So all of these things that they initially said that the authors of the WHI had stated for reasons why women should not go on hormones was then proven to be false and not statistically significant. And so, we know that for the majority of women, that menopausal hormonal therapy is actually safe. Okay, so the most important results of 20 years of median follow-up, the WHI confirmed that menopausal hormonal therapy does not increase breast cancer mortality, and there was not statistically significant effect of combined menopausal hormonal therapy, but that there was a statistically significant reduction in breast cancer mortality with estrogen alone. So even so, right, it was important to note that estrogen alone does reduce the breast cancer mortality. So that was important to note. Okay, so a meta-analysis of the randomized controlled trial confirms that beginning menopausal hormonal therapy within 10 years of menopause or less than the age of 60 is associated with a 30 to 50% reduction in all-cause mortality and coronary vascular disease. Whereas if you begin after that time frame, these benefits are not seen. Okay, so that's why the timing hypothesis, and we're going to get into that next actually, is really, really important, right? It's important to note that timing does matter for hormones. And so let's talk about it. And they also know that beginning benefits of beginning hormones within the time frame include reduced risk of all-cause mortality. That is super important, right? And fractures. Fractures are huge. We know that when women become osteoporotic, that 1 in 2 women will have a fracture, and a fracture that they may not recover from and may die from. So really, really important to realize that we have to, maintain our bone density, right? Keep our bones really strong and keep our heart strong. And those are super important things to know. Menopausal hormonal therapy is associated with a reduction of 50%. That's huge, right? 50% reduction in heart attack risk, 64% reduction in cognitive decline, and a 35% lower risk of Alzheimer's. So again, this is all assuming that you start within that critical window. Okay, so let's talk a little bit about the timing hypothesis. Okay, so the most important conceptual development in menopause medicine over the past 2 decades is this timing hypothesis, okay, or it's sometimes called the critical window hypothesis. The core principle is this, is that the risk-benefit profile of menopausal hormonal therapy is not static. It's determined when the therapy is initiated relative to the onset of menopause. Okay, so all of the societies say it, and we're going to talk a little bit about like, well, what if you're older, right? What if you're in your 60s and in your 70s? Can you start hormones? And honestly, we don't have a lot of data on that, but let's talk a little bit about, what the data that we do have, what it shows. Okay. So the ideal time, so the favorable window is that women who begin hormones within 10 years of their last menstrual period or who are under the age of 60 are in what we call this critical window. Okay. And in this group, multiple analysis, including a Cochrane review, meta-analyses, and the WHI's own 18-year follow-up show cardiovascular benefit. Okay. Possible mortality reduction, and not just possible. We know that all-cause mortality actually does go down, and it was statistically significant, and a favorable overall risk-benefit ratio, right? So the Menopause Society, ACOG, Endocrine Society all endorse that if you're going to start hormones, it's best to start within this time frame. Then there's this neutral zone, women who are 10 to 20 years past menopause, right, or into post-menopause, or between the ages of 60 and 70. They fall into this more equivocal zone. Okay, so cardiovascular effects are neutral to variable. This population requires individualized assessment. So we're not automatically saying no, but we're saying you have to do the work. You have to take a look, what is their ASCVD risk ratio? You have to take a look at, what is their heart? Do they have plaque buildup in the heart? Are they really going to benefit here? And for a lot of women, they are. Right. So, can women that are older than 60 get hormones? Absolutely. You just have to go to the provider that will take a look into your history, take a look to see if the benefits outweigh the risks. And then, you and your provider make that decision. You have to assess your specific risk factors. Okay. And so then, new initiation after 20 years, right? So let's say you're in postmenopause and you want to start and you're over 20 years out. So for women that are more than 20 years postmenopausal or over the age of 70 who have never been on hormones, new initiation carries potential increased cardiovascular and cognitive risks. And so the typical answer is that we don't give hormones for women that are over 70. So, but there are some providers that will, and they think that, starting hormones, even body identical ones. Now, remember, so we're going to talk a little bit about synthetic hormones and body identical ones. So we're talking here about the body identical hormones, which are the ethinyl estradiol and the micronized progesterone. And there are some people, some practitioners out there that feel that using body identical hormones is safe for even individuals in their 70s, okay, that have really no other great comorbidities, right? And so, again, you have to go to your provider. You have to see if you would be an ideal candidate or not. Now, let's talk a little bit about that removal of the black box warning. So what happened? So in 2025, something historic happened, and that was that the FDA removed the black box warning from the estrogen therapy. And it really was a landmark moment. I'm proud to say that I was there when they announced that removal of the black box warning, and that was actually November 10th, 2025. I'm proud to say that I was there on November 10th, 2025, when they announced that the black box warning would be removed. So let's take a look at the timeline. Okay, so in 2003, so what happened? So following the 2002 WHI publication, the FDA added a black box warning to all hormone therapy products, right? The warning cited that there was increased risk of breast cancer, cardiovascular disease, dementia, and it was actually the most restrictive label that was possible. And it landed on all products and all estrogen products, right? And so people were thinking that they would get a heart attack from using vaginal estrogen, and that we know that that's not true. The effect, of course, was immediate and devastating, and prescriptions dropped by more than 50% literally overnight. Women stopped therapy without tapering, and providers who had been prescribing appropriately stopped prescribing, right? So in 1999, just to show you how dramatic of a drop it was, in 1999, 27% of American menopausal women used hormone therapy. By 2003, it was 16,000. And by 2020, it was only 5%, right? So there was a huge drop. And to be honest, most practitioners were not having that discussion with their patients. And I will tell you that I wasn't either, right? I mean, if you don't know and you're not keeping up on the information that's coming out, then you are going to be stuck with, the thoughts and the medical dogma that we were trained with, which was that you don't prescribe hormones. And if you do, you prescribe the least amount for the shortest amount of time, which actually I would say I was at a conference and I had a colleague that literally said that. And I was like, no, 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 we don't believe that anymore. That's not true. So anyway, so in 2007, the WHI investigators began publishing reanalysis, and one of the most important findings at that time in the estrogen was that in the estrogen-only arm, women who had hysterectomies who were not taking that progestogen, there was no increased breast cancer risk. In fact, there was a trend toward reduced risk, and this was barely covered in the mainstream press, right? In 2017, the Menopause Society formally recommended that the black box warning be revised. So even the black box warning didn't come off until 2025. Back in 2017, the Menopause Society was saying, hey, listen, this black box warning is inappropriate. We shouldn't have it. In 2022, the Menopause Society's comprehensive position statement affirmed that for healthy women under 60 or within 10 years of menopause, menopausal hormonal therapy the benefits outweighed the risks. And it was directly contradicting the framing of the black box warning. Okay, so now in 2025, what happened, right? So the FDA removed the black box warning on estrogen therapy. There was a class-wide boxed warning removal from local vaginal estrogen products. So all vaginal estrogen products have that black box warning removed. Breast cancer history was removed as a contraindication for vaginal estrogen. For systemic menopausal hormonal therapy, breast cancer risk language was removed from the box warning. Breast cancer history remains listed as a contraindication, and the labeling does not distinguish between estradiol versus conjugated equine estrogen or the progestogen type. So the black box warning, even though it came off, some of the labeling is still there, and it does not make that distinction between the body identical hormones and the synthetic ones. Okay. So now what do we make of all of this? So now it's really important that we as physicians, if you're a physician that's listening to this, that it's important that we disseminate this information to our patients and, they get all the information that they need. All right. So what are the indications for menopausal hormonal therapy? So let's talk about, who benefits from menopausal hormonal therapy. Now that we kind of went through the whole WHI, we know where we came from and where we're going now. What does the evidence tell us about each indication? And so we'll talk a little bit into primary indications, those with strong FDA level evidence, and additional benefits where the evidence is emerging or consistently supported but not FDA indicated. Okay, so what are some primary indications, right? So we have some of the indications are vasomotor symptoms, genitourinary syndrome of menopause, premature ovarian insufficiency, surgical menopause. We know that those are some indications for taking hormones, right? So we know vasomotor, of course, the hot flashes and night sweats, that's the main FDA indication, are the primary FDA approved indication for menopausal hormonal therapy. And a 2022 Cochrane Systemic Review confirmed that hormone therapy reduces vasomotor symptoms way better than a lot of other options that we have. And it reduced the frequency by approximately 75% compared with placebo. That's huge, right? So 75%, and that is superior to every non-hormonal alternative available. No other agent comes close. So that's what I was talking about, is that, even though we do have non-hormonal therapy that we'll talk about a little bit, The gold standard really is estrogen if you are able to take it. The 2002 Menopause Society position statement names menopausal hormonal therapy as the most effective treatment for vasomotor symptoms. Okay. All right. So let's talk a little bit about the gender urinary syndrome of menopause. So that encompasses vaginal dryness, pain with sex, urinary urgency, recurrent UTIs. It affects about 50% of postmenopausal women, but I will tell you that I think it's more than that. I think it affects everyone. And why is that important? Well, the thing is, with the gender urinary syndrome menopause, it actually progresses and gets worse, right? It doesn't really get better. So some women are like, don't worry about it. I'm just going to deal with it. Well, sure, you can deal with it. It's just going to get worse as time goes on. It affects about 50% of postmenopausal women, and unlike vasomotor symptoms, does not resolve on its own over time, right? It's progressive if it's undertreated. And that's kind of what I was saying before. Both local and systemic estrogen are highly effective. Low-dose vaginal estrogen is important because it has minimal systemic absorption. And so, the way that I describe it to my patients is that when you take vaginal estrogen, if you're using the cream, it's kind of like moisturizer for your face. You kind of, you have to rub it in. If you use that applicator and you just plunge it into the vagina, when you stand up, all that is going to come out, right? That's why I feel like you really have to rub it into the tissues. And that's where I see that most people find that it is beneficial, right? Is when it really gets in there. So both local and systemic estrogen are highly effective. Low-dose vaginal estrogen is important because it has minimal side effects, right? Not only side effects, but minimal systemic absorption, rather. So low-dose vaginal estrogen is important because it has minimal systemic absorption. And so this makes it eligible for a wide group of patients, right? Including women over 60, those with cardiovascular factors, and some with a personal history of breast cancer in consultation with their oncologist. So most women can have vaginal estrogen. I will say that there is a category of women that cannot have vaginal estrogen, and that would be leiomyosarcoma or sarcoma of the uterus. And that is listed in the British Menopause Society. They have these tables, and those are the two subgroups that I have seen that, they say is absolutely, they can't have it, unfortunately. But most individuals, even those that have had breast cancer, can have vaginal estrogen. Okay. Premature ovarian insufficiency is defined as a loss of ovarian function before the age of 40. It affects approximately 1% of women. And for these patients, menopausal hormonal therapy is not an option. I mean, you really need to, if you are going to, like, if you have lost ovarian function before the age of 40, you really, really, really need hormones, because you got to protect your heart, you got to protect your bones. You're going to start to have this gender urinary syndrome menopause. So it's indicated at least until the natural age of menopause, which is around 51, 52. And without hormonal replacement, these women face significant risk of osteoporosis, right? I mean, that's key. Osteoporosis, cardiovascular disease, cognitive decline, premature mortality, all of these things, because their ovaries decided that they weren't going to function anymore before the age of 40, right? Also, if you worry that, perhaps somebody has this and they've gone, let's say, like 4 months or so without a period, it's really important to get blood work done and check their FSH level and see if it is above 25. Okay. So women with premature ovarian insufficiency who began menopausal hormonal therapy before the age of 40 appear to have the most significant longevity advantage. And so this is a population where early proactive treatment is really, really critical. Okay. Surgical menopause. So surgical menopause is another one of those things that we need to treat aggressively. And it's because bilateral oophorectomy, right? So if both of your ovaries have been removed, there's an abrupt, complete menopause that happens at this age, okay? And there's no transition period. And testosterone also drops sharply by approximately 50% because the ovaries are the primary source of androgens in premenopausal women. And remember, we do get a little bit from the adrenal glands as well, but the ovaries make the majority, okay? So for women that have had a bilateral oophorectomy, estrogen replacement, and androgen assessment is really, really recommended. So For if you've had both of your ovaries removed, you do need to be, if you are able to, it's important for you to go on estrogen and progesterone, and then also testosterone if that's something that's important to you, okay? Because, like it said, half of your testosterone, 50% of your testosterone is produced by your ovaries. So you should consider replacement if you haven't already thought of that, okay? Without a uterus do not require a progestogen. So let's say, you had to have your ovaries removed and you had all this crazy bleeding. And so you decide to get a hysterectomy. We know that you don't have to take a progestogen, right? That's not required if you don't have a uterus. Okay, so we also know that observational evidence suggests that micronized progesterone carries a lower breast cancer risk than the synthetic progestins. However, there's no randomized controlled trial to address this question. So, what are some additional benefits that we have for our menopausal hormonal therapy? Well, we have bone protection, we have cognitive function and mood, we have cardiovascular risk reduction, we have metabolic health, we have all-cause mortality. Now, remember, the WHI study says, and, people that look to assess it, also the American Heart Association says that we should not be starting hormones for, heart health or to prevent heart disease, but it does help. And, we're going to get into that because, we know this from studies that have been done. Okay. So let's talk about bone protection. So estrogen has a well-established anti-resorptive effect on the bone, right? So a 2025 Cochrane review confirmed that estrogen-only therapy reduces all fractures. So that's really important. Also, what's important to know is that long-term data suggests that estrogen may be more effective than bisphosphonates. We know that, bisphosphonates are great, but, there are side effects. And I will tell you, I had a patient once that had some issues with her jaw, right? And we know that with bisphosphonates, you can have this osteonecrosis of the jaw. And so she was not able to take those bisphosphonates. Also, I had a patient who has osteoporosis, and her provider actually wanted her to get an x-ray of her jaw before they would start and go to a dentist and have her, mouth evaluated before they would start the bisphosphonate. So really interesting. But, you do need to know the side effects. So the long-term data suggests that estrogen may be more effective than bisphosphonates in preventing femoral fractures, which is really key. Menopausal hormonal therapy is appropriate as a bone protective agent when other options are contraindicated. A practical note is that supplementation of 1,200 milligrams of calcium and 800 international units of vitamin D should be discussed for daily intake along any fracture prevention strategy. Okay, so that's really important. Also, okay, so what are some additional benefits of menopausal hormonal therapy? We have cognitive function and mood. So perimenopause is associated with significant mood disturbance, cognitive fog, sleep disruption, anxiety, and that's separate from any underlying psychiatric illness that a patient may have already had, right? So these symptoms are neurobiological in origin and respond to estrogen when treatment begins within the critical window. And there is growing body of evidence that early initiation of menopausal hormonal therapy may be protective for brain health, not curative for Alzheimer's disease, but potentially delay inducing when started early. And that actually is research that we know that Dr. Lisa Mosconi is working on with Weill Cornell. And so she has a lot of funding for that to look into Alzheimer's. Okay. There's an active area of research. What we can say is that estrogen receptors are present throughout the brain, right? We know we have estrogen receptors throughout our whole body. And estrogen has documented effects on neurotransmitter function, neuroinflammation, and cerebrovascular health. So that is really important. Also important to note is CBT, cognitive behavioral therapy, is also an effective non-hormonal option for vasomotor symptoms, hot flashes, night sweats, mood, and sleep improvement, and it should be a part of the toolkit that we discuss. I will say that, although it is suggested by the Menopause Society, the cognitive behavioral therapy, of course, nothing is going to work better than hormones, right? Estrogen, because we know that there are estrogen receptors throughout the brain. So that, if the brain is low on estrogen, we know that that's probably going to work the best. Okay, let's talk a little bit about cardiovascular risk reduction. So when hormones are started within this critical window, right, less than the age of 60 or within 10 years of menopause, Multiple analyses show that estrogen reduces coronary heart disease risk by 40 to 50%. That's huge, right? 40 to 50%. More reliably than statins, according to some analysis. And the WHI's own 18-year follow-up demonstrated reduced all-cause mortality in women who started estrogen before the age of 60. The ELITE trial, which was published in the New England Journal of Medicine 2016, showed that menopausal hormonal therapy slowed atherosclerosis progression, which was measured by carotid intima media thickness when started within 6 years of menopause. Okay, so there was no effect when was observed when hormones were started more than 10 years post-menopause. And this is the endovascular evidence for the timing hypothesis. So really important, right? That if you're going to take hormones and if you can optimize it, then best to take it within 10 years of menopause or less than the age of 60. Okay. Menopausal hormonal therapy reduces the incidence and new onset of type 2 diabetes. The Endocrine Society recommends transdermal estrogen, right? So estrogen that is by this, the transdermal estrogen. So any hormone, right, that goes through the skin in women with metabolic syndromes such as obesity or high blood pressure, and routes that avoid the first pass hepatic metabolism and does not worsen lipid profiles or increase the stroke risk, right? Menopausal hormonal therapy also reduces the incidence of type 2 diabetes, which is huge, right? Because a lot of women, we know that due to the hormonal shifts that happen perimenopause, a lot of women will develop this metabolic syndrome. And so we know that the estrogen will help with that. All-cause mortality. Okay, so the point is not sufficiently emphasized in clinical training, and this is why this is really important. In every decade of life past the age of 40, more women die of heart disease than of breast cancer. And that is really, really important, right? Menopausal hormonal therapy is a critical window that given in the critical window, right? So menopausal hormonal therapy given in the critical window reduces all-cause mortality. The 18-year follow-up of the WHI published in JAMA confirmed this for the estrogen-only arm. And we know that, that is really, really important. Okay, so who's a candidate? Let's talk about that. Now that we know the indications, let's talk a little bit about who's a candidate and who should we be offering this these hormones to, right? All right. So who is a candidate? Who is a candidate for menopausal hormonal therapy? So the people that are appropriate candidates, right? So these are what the guidelines state. Your ideal menopausal hormonal therapy candidate is somebody that is symptomatic under the age of 60 or within 10 years of their last menstrual period with no absolute contraindications, right? So within that definition, the following specific groups represent strong indications. So one is like a woman with surgical menopause at any age, bilateral oophorectomy, are candidates regardless of age, right? So those women that have had their ovaries removed regardless of age are a candidate because their menopause was not natural and not gradual, right? So they're going to have symptoms right away. So you're going to want to take care of that. Women with premature ovarian insufficiency under the age of 40 should absolutely be treated, right? Because we're trying to protect their heart, their brain, their bones, all that stuff. And so they should almost universally receive menopausal hormonal therapy until the natural age of menopause, with a few exceptions, of course. And, that's if they are, and we'll get into what are the contraindications. Women with moderate to severe GSM who have failed or declined. So remember, GSM stands for genitourinary syndrome menopause. And those women that have failed or declined non-hormonal therapy, whether systemic or local estrogen, depending on the severity of patient preference. Women with osteoporosis, a risk who prefer to avoid bisphosphonates or for whom bisphosphonates are contraindicated, right? So those are appropriate candidates. And I'm sure it's not completely exhaustive, but these are some of the appropriate candidates, right? Absolute contraindication is that those that have undiagnosed abnormal vaginal bleeding, of course, you don't want to give them hormones if you don't really know where this bleeding is coming from. We always need to exclude endometrial pathology before prescribing estrogen, right? That's a given. Active thromboembolic disease, deep vein thrombosis, or pulmonary embolism, though, as we'll discuss, the transdermal route significantly modifies this risk profile, right? Active liver disease or impairment, known estrogen-dependent malignancy, and unexplained stroke or MI within the past 6 months, protein CNS deficiency or antithrombin 3. Breast cancer history, deserves, is more nuanced, right? So we just can't say yes or no. We have to figure out all the details with the breast cancer. So that's really important. There's no evidence-based guideline that recommends arbitrary time limits on menopausal hormonal therapy. Okay, so the Menopause Society explicitly states that the treatment should be individualized and that there's no preset duration after which therapy must be discontinued. So that's really important because, we have, I've had people or patients, ask me like, so when do I need to come off? Do I only stay on for 5 years? What do I do? And so basically, we don't have a time limit to hormones. So if you want to be on it forever, you can be, as long as you're going in, being managed by a physician, being watched, that you're getting your yearly mammograms, all that stuff. We got to make sure everything is okay as we give you the menopausal hormonal therapy. Okay. So what we want to do, right, what we said is, there's no arbitrary time limit, but of course you do want to assess every year the risk benefit ratio, and see whether or not hormones are still benefiting you, right? Okay, so what is a clinical practice framework for initiating menopausal hormonal therapy? So what we could do is, what I want you to do is step one, assess symptoms, right? Use validated tools, use the menopause quality of life questionnaire, find out how the patients are doing, characterize their vasomotor, physical, psychosocial, and sexual domains, and see what's going on there, right? You can use that female sexual function index, is a validated tool for sexual symptoms. And so you want to address that. Okay. Don't be like one of those providers that never asks about sexual health. Okay. I want you to go and ask. And, if it's uncomfortable for you to ask about sexual health problems, then I want you to be uncomfortable and then become comfortable the more you ask, right? That's the only way we get better. And for patients that may be listening, I want you to go and talk to your providers about everything, right? And if you sense that they are uncomfortable, it doesn't matter. This is about you and you need to get answers. So make sure that you ask your provider the questions that you may have. Okay. Step two, screen for any type of contraindication. So step one was to assess for patient symptoms. Step two is to look for any type of contraindications to menopausal hormonal therapy. Can everyone get it? Does, and there are some people that are not able to get it, right? So we have to make sure that we're screening out for those people. Step three is to stratify cardiovascular risk, right? You want to calculate the 10-year ASCVD risk score. You want to apply the timing hypothesis. You want to identify women who would do better with transdermal than with oral. You also want to look at, if they have metabolic syndrome, if they have obesity, high blood pressure, diabetes, dyslipidemia, all of that stuff. Okay, step four, choose the formulation. So we know that transdermal, right, anything that goes to the skin, plus oral micronized progesterone. So this is the thing, right? You have to choose a formulation. So you want to pick something that is going to be really, really beneficial to the patient. So what I usually do is I will pick body identical hormones. And so we have them doing transdermal estradiol plus oral micronized progesterone in people that have a still uterus. Okay. And this transdermal estradiol with the micronized progesterone is the regimen with the most favorable safety data. Okay, so we'll cover formulation options in the next section, but consider even an IUD as an alternative for endometrial protection, right? We know that if a patient has IUD, we know it's good for about 5 years for endometrial protection. If you're using it alongside a menopausal hormonal therapy. For contraception, we know it's with the Mirena specifically, it is about 8 years, right? That it's has contraceptive benefit, but if you're using it for to protect the uterus against endometrial cancer, right, or for uterine protection with menopausal hormonal therapy, then we know that we use it for about 5 years. Okay. Counsel with context, step 5. So this is where informed consent becomes an act of clinical excellence. So you got to present the absolute risk, not just the relative risk. Compare with the absolute breast cancer risk of menopausal hormonal therapy, which is about less than, one additional case per 1,000 women year, depending on the formulation. And it's not with the body identical hormones, right? It's more, we see that risk more with synthetic hormones. And that risk of one additional case per 1,000 women year is about the same as that risk attributable to obesity or daily alcohol use. Okay, so you got to know that. Step 6. Okay, so this is the sixth step: is you have to monitor and assess annually. So reassess the symptoms, the risk factors, and other patient goals. And of course, if unscheduled bleeding occurs, you got to work that up, right? And ACOG just came out with a new practice bulletin for postmenopausal women, but that was for postmenopausal women that are not on hormones. It's just talking about how you need to do a transvaginal ultrasound along with an endometrial biopsy at the first time that you see them. And that was because a lot of women get lost to follow up. And then when they come back, they may have high grade cancer. And so, because of that, they want us to do an endometrial biopsy and a transvaginal ultrasound at the onset when somebody comes in for postmenopausal bleeding. The one thing is that, the difference is when somebody starts hormones within the first 6 months, they can have some bleeding with that. And so you don't always need to jump to an endometrial biopsy with those. You can wait a little bit, because we know that within the first 6 months, it is a known, let's say, a side effect of menopausal hormonal therapy. And we make sure that we don't start biopsying everyone that comes in with menopausal hormonal therapy and that is bleeding, if it's still within that first 6 months, right? Let's see here. So if unscheduled bleeding occurs and persists beyond 6 months on menopausal hormonal therapy, we want to work it up. Transvaginal ultrasound is the initial investigation. On continuous combined menopausal hormonal therapy, an endometrial thickness greater than 4 millimeters is considered abnormal and warrants further evaluation, right? And we talked about that. So ACOG just published a clinical practice bulletin on receiving both transvaginal ultrasound and endometrial biopsy for initial evaluation for somebody that is not on hormones. Okay. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.